Hello and welcome. This video will cover all of the information for this topic. Feel free to watch the full video, or if you prefer, you can scrub along the timeline at the bottom and jump straight to the section of your choice. Physical fitness can be defined as a state of well-being that provides optimal performance and is an outcome of regular physical activity. Regular physical activity and exercise should encompass both health and skill, also known as motor fitness, for a balance in both health and physical well-being. The different components which make up health include cardiovascular fitness, muscular endurance, muscular strength, flexibility, and body composition. The different components which make up skill or motor-related fitness include coordination, reaction time, agility, power, balance, and speed. We will look at each of these different components of both health and skill or motor-related fitness in more detail now. Health-related fitness is the ability of the body's systems to work optimally and efficiently for all-round health and wellness. The different health-related fitness elements include cardiovascular fitness, which is the optimal functioning of the heart, lungs, and vascular system. Muscular endurance, which is prolonged muscular effort without fatigue. Muscular strength, which is maximal muscular force against a high resistance. Flexibility, which is an optimal range of movement at a joint or series of joints. And finally, body composition, which is an optimal proportion of both fat and fat-free mass. We will look at the recommended guidance now to improve all of the different health-related components, and we will do this using the FIT training principle. The definition of cardiovascular fitness is the ability of the heart, lungs, and muscles to take in, transport, and utilise oxygen during exercise. It is also referred to as the cardiorespiratory, stamina, or aerobic fitness. Cardiovascular activities increase heart rate and breathing rate, with the aim of speeding up blood flow and delivering more oxygen to the body to produce energy aerobically. Activities which improve the efficiency of the cardiovascular system and increase cardiovascular fitness are those which use large muscles in a continuous and rhythmic way and which elevate the heart rate and respiration rate. These activities include walking, swimming, running, cycling, rowing, and activities such as dancing. The recommended FIT principle training guidelines to develop cardiovascular fitness are to train 3 to 5 days a week, either at a moderate intensity of around 40 to 65% of the maximum heart rate, or a vigorous intensity of between 65 and 100% of maximum heart rate. The minimum amount of moderate intensity work which is recommended is 150 minutes per week, with vigorous intensity being half that of around 75 minutes per week. Both of these times can be separated throughout the week in smaller amounts, with moderate intensity in bouts of 10 minutes or more, and vigorous intensity in bouts of 20 minutes or more. Individuals completing moderate activity will be doing so aerobically, whereas individuals completing vigorous activity will be completing this anaerobically. The definition of muscular endurance is the ability of the muscles to work continuously under low to moderate resistance, whereas the definition of muscular strength is the ability of the muscles to exert maximum force against a high resistance. Daily activities that require muscular endurance include activities of daily living, such as carrying shopping, climbing the stairs, and gardening. All activities of daily living require elements of muscular strength. Having an increase in muscular strength makes these activities relatively easier to complete. Activities that will improve both muscular endurance and muscular strength include a resistance training program which focuses on all of the major muscles of the body, such as those achieved in compound movements. The recommended fit principle training guidelines to develop both muscular endurance and strength is training 3 to 5 days a week, either at a moderate intensity of 40 to 65% of 1 repetition max for muscular endurance, or a vigorous intensity of over 85% of 1 repetition max for an increase of strength. The minimum amount of moderate intensity work which is recommended is typically over 12 reps for 2 to 3 sets for each of the major muscle groups per session, with vigorous intensity being half that at around 1 to 6 reps, but over 2 to 6 sets. It may be more appropriate to use resistance machines for endurance training, as there is less danger to safety during times of higher repetitions and muscular fatigue, as movement is limited within the machine. It may be more advantageous to use free weights during strength training, as this will recruit more muscle fibres due to fixator and synergistic activation, leading to greater overall strength outcomes. All exercises should be appropriate to meet the needs of the client's goals, enjoyable, and consideration to the client's current fitness and skill level should be met. The definition of flexibility is the range of movement possible at a joint or a series of joints. Flexibility is determined by the shape of the bones and cartilage, and by the length of the muscles and connective tissues that cross over a joint. Flexibility can vary enormously from one person to another, and is specific to that individual. It is important that individuals develop and maintain appropriate levels of flexibility suitable for themselves, which enables individuals to carry out their activities of daily living and ensure appropriate posture which is suitable for the individual. Activities that improve the flexibility of an individual are passive or active stretching techniques. Passive techniques are where the stretch is achieved by an external force, such as a door frame or another person. Active stretching techniques are where the muscles and connective structures are being stretched using the body's own ability. The recommended fit principle training guidelines to develop flexibility are to train 2 to 3 days a week, ideally every day, and always only to mild tension. This is to avoid injury. Individuals looking to maintain their flexibility should hold a stretch for between 10 and 30 seconds on each of the major muscle groups, whereas individuals who are looking to develop their flexibility should hold a stretch for 30 to 60 seconds on each of the major muscle groups. It is recommended that stretching should be completed statically by holding a stretch position and avoiding overstretching or exceeding the range of motion. This will reduce the possibility of DOMS. It is also advisable to complete flexibility training after an appropriate warm-up to reduce the possibility of any injury. The body is comprised of fat-free mass, which includes bone, organ, and muscle tissue, and is also comprised of fat mass, which includes both visceral and subcutaneous fat. It is the fat mass, in particular the visceral fat, which poses significant risk to health. Body composition is typically measured as percentage of body fat, which serves as an effective indicator of overall health. Two individuals may be of equal weight and height, therefore have the same BMI, but their body composition and appearance may be totally different. This is as muscular tissue takes up less space in the body than fat tissue. The point at which body fat becomes a risk to health varies between sexes, ethnicities, and age groups. Recommended guidance for optimal health is to maintain fat mass at around 8 to 25% for men, with a fat-free mass of 75 to 92%, and to maintain fat mass around 21 to 36% for women, with a fat-free mass of between 46 and 79%. The second element of physical fitness is skill or motor-related fitness. This is the ability of the body to perform various tasks which can be improved through training of the neuromuscular system over time. There are 6 different skill or motor-related fitness elements, and these can be remembered by the acronym CRAP-BS. These include coordination, which is the ability to smoothly move 2 or more body parts under control, accurately and efficiently. Most activities require some form of coordination, such as kicking or throwing or catching a ball. Reaction time. This is the ability to respond quickly to a stimulus. It's important in many sports and day-to-day activities. Simple reaction time is the time taken between stimulus and a movement, and includes catching an item which you have accidentally dropped. Agility is the ability to change the position of the body and move in a different direction quickly, such as changing direction when walking or running. Power. This is the ability to exert maximum muscular contraction instantly in an explosive burst of movement. The 2 components of power are strength and speed. Many activities involve power, such as standing from a seating position and picking up and carrying the shopping. Balance. This is the ability to control the body's position when either stationary or while moving, such as standing in one place on one leg. And speed. This defines how quickly a movement can be performed in a short space of time. Speed is required for many activities, including sprinting and throwing. We'll look at the recommended ACSM and NHS guidance for skill or motor-related fitness now, using the FIT training principle. Training to improve skill or motor-related fitness depends on which component an individual wishes to improve and for what specific purpose. For example, reducing the risk of falls in older adults, it will be beneficial to incorporate a mixture of reaction, coordination and balance activities throughout the weekly training program. To see improvements in specific components, it is recommended that individuals train the component 2 to 3 days a week, ideally every day, at an intensity suitable to the individual's skill set and experience. Individuals should aim to achieve between 20 and 30 minutes on the particular skill throughout the session to see improvement, with the type of activity or exercise being specific to the requirements of the skill. Cardiovascular training develops the ability to take in, transport and utilise oxygen. The long-term benefits of cardiovascular training include the heart becoming stronger, with more blood being circulated in one contraction or heartbeat. This is known as an increased stroke volume. There will be an increase in the number of capillaries in the muscles and in the alveoli within the lungs, both of which increase in the potential for gaseous exchange to occur. The increased number of capillaries, along with greater volume of blood, enables waste products to be removed more efficiently. There will be an increase in both quantity and size of mitochondria, enabling a greater amount of aerobic cellular respiration to occur. They will also use greater fat stores as fuel and assist in weight management. This will reduce the risk of cardiovascular disease or acute events occurring, such as coronary heart disease or stroke. The different forms of resistance training develop the musculoskeletal system over time. The long-term benefits of both muscular strength and muscular endurance training include having stronger muscles, tendons and ligaments, improving joint stability, having stronger bones via increased bone density, improving muscle tone, giving both improved neuromuscular connections and motor unit recruitment for greater motor fitness and better posture. Having a greater amount of muscle improves body composition by having a greater basal metabolic rate and the ability to work more vigorously at a reduced perceived intensity. By maintaining musculoskeletal properties via resistance training, there is a reduced risk of developing degenerative musculoskeletal conditions such as osteopenia or sarcopenia. Flexibility training develops both the neuromuscular system and the associated connective tissues. The long-term benefits of flexibility training include improved neuromuscular control and proprioception, making movements more efficient and effective, as there is a greater awareness of where the body is in space. Flexible and balanced muscles improve both posture and range of motion available at a joint. Muscles at the correct length improve both physical and mental relaxation, as there is less muscular tension. This reduced muscular tension improves muscle functionality, enabling contractions to become easier and smoother, and reducing the risk of joint or muscle strains, such as pulled muscles or lower back pain. Having an optimal body composition has a positive impact on both an individual's confidence and their health. Benefits of optimum body composition include an increased metabolism due to good lean to non-lean tissue ratio. This leads to an increase in proprioception and functional ability. Individuals with an optimal body composition will also benefit from increased virility and having an improved mental well-being. Ensuring a healthy body composition reduces an individual's risk of developing chronic health conditions or comorbidities associated with being overweight. To make appropriate adaptations to a training stimulus, we can effectively use the FIT training principle, which enables specific adaptations of training to take place by either progressing or regressing the frequency, intensity, time, or type of exercise. There are also a variety of other further key principles to the FIT training principle, which also need to be considered and applied when designing an exercise program specific to the needs of a client. These key principles of training need to be recognised to ensure individuals continue to progress towards their health and fitness goals in a safe and effective manner. The key principles of training include specificity, individuality, adaptability, progressive overload, recovery time, and reversibility. Specificity is known as the set principle of training and is where a specific adaptation will be brought about by a specific training stimulus. For example, if somebody wishes to develop their speed to be able to run faster, then they will have to train their speed for these specific adaptations to take place. This is possibly the key principle in training and adaptation, and we will look at this principle in more detail in the next slide. Individuality is similar to specificity, however relates to an individual and not the task. An individual's training potential is influenced by their personal attributes. Everybody is different, and there is no one-size-fits-all method for programming. This is why programming must be created personal to the individual. For example, two clients may be the same height and weight and have the same goals to lose fat mass. However, both will have to be programmed differently, as there may be many individual factors which will make programming different, such as the somatotype and body composition of the individual. Also, individuals respond differently to the training stimulus. This brings in the next key principle of training, which is adaptability. Adaptability is where the body reacts and adapts in accordance to the specific training stimulus placed upon it. Everybody will respond and adapt differently at different rates, and this must be programmed for. This is achieved through monitoring an individual's progress over time and making appropriate changes when necessary. To continue to progress, progressive overload must be factored into a client's programming. Progressive overload is continuing to increase the demands over time. One of the biggest reasons for non-adherence to exercise programs is the lack of progress and challenge over a sustained period of time. It's vital to continue to challenge the body's systems by gradually increasing the difficulty of exercise sessions. This can be achieved using the FIT principle of training to adapt the training stimulus of an individual, such as changes to frequency or volume of the activity, changes to the intensity in terms of the work-rest ratios, heart rate, or rate of perceived exertion, for example. The level of progressive overload applied will be determined by the current fitness level of an individual and their goals. An untrained sedentary individual may need comparatively small changes to bring about a specific training effect, whereas a trained individual may need a greater challenge. It should be noted that the body cannot continually adapt indefinitely, as everybody has a genetic ceiling. Also, adaptation should be gradual and incorporate the recovery principle to allow the body's systems to adapt and avoid overtraining. If the body fails to recover, then this could lead to overtraining and cause temporary referral of exercise through illness or injury. If an individual stops exercising, then the adaptations which they have achieved will subside and be lost. This is known as reversibility principle. Use it or lose it. The rate of decline is determined by the fitness of an individual, the level of stimulus reduction, and the length of time of which a stimulus has been reduced. Total inactivity or lack of movement for extended periods of time contributes to loss of all developed adaptations and increase the risk of many chronic health conditions. To maintain optimum function, all body systems need to be trained regularly and at appropriate volume, with considerations to all of the key principles of training. However, special consideration and understanding should be given to the specificity of training and progressive overload in terms of FIT training principles of adaptation. The specificity of training principle, which we have just covered in the previous slide, is also known as the SAID principle of training. This is the primary principle of training, and the acronym stands for specific adaptation to the imposed demand. Now, the specific relates to the training stimulus needed to mimic the desired response. So, for example, if an individual would like to improve their cardiovascular health, then the training stimulus would need to be cardiovascular based. This is due to the ability of the body to be able to adapt over time. These adaptations occur due to the body's ability to change to specific imposed stimulus, making future exposure to the stimulus easier over time, as the body's systems supercompensate in reflection of the demand which has been imposed. Essentially, by training specific to the area of required improvement is the biggest factor of improving that particular component of health. Some influencing factors to consider when programming for individuals includes their physique or body type. An individual's body type has a significant impact on their ability to perform various physical tasks successfully. A simple system for visually assessing body type is the system of somatotyping, which suggests that there are three distinct body types: ectomorph, mesomorph, and endomorph. Ectomorphs are naturally thin, with little body fat and relatively reduced muscle mass, and have a high predominance of slow twitch fibers. This makes them ideally suited to low intensity, long duration activity. Mesomorphs tend to be naturally lean and muscular, with broad shoulders and narrow hips, and have a high predominance of intermediate twitch fibers, which makes them adaptable to most training stimulus. The third somatotype is endomorph. These individuals are naturally predisposed to high fat storage and have a high predominance of fast twitch muscle fiber type, which makes them naturally suited to high intensity, short duration activity. Awareness of body types or somatotypes is useful when discussing client objectives, as it will be a factor to limitations of the body's adaptations. However, the suitability of certain activities should always be conducted with sensitivity. Age is another influencing factor, as the body changes throughout a lifetime. Individuals should be trained to their physical age and not their chronological age. A person's fitness is generally greatest in their 20s and then declines with age. For older adults, the change to the body systems, which progressively results in weaker muscles, lighter bones, stiffer joints, slower reflexes, and an increase in body fat, will reduce their training potential. Benefits can still be achieved, but the rate of which developments occur will be slightly slower. Age-related changes generally begin to occur at the age of 50 and make their mark around 65. The onset of the aging process and the rate of decline are influenced by regular physical activity and exercise. Gender is another influencing factor affecting physical activity. There are a number of anatomical and physiological differences between both men and women that influence their training potential. Increased levels of testosterone in men mean that active males grow stronger due to greater increase in muscle mass. Activity level is also a big influencing factor, as inactivity and leading a sedentary lifestyle offer an increased risk of poor health. Inactive individuals who don't exercise regularly generally have reduced mobility and flexibility, limiting the exercise and activity that they can perform, whilst also perceiving less demanding activity to be more vigorously demanding than it is. The body needs specific nutrients in an individual's diet for energy, growth, and repair of the body systems. A healthy, balanced diet will help ensure that the body is functioning optimally and recovering from the demands of physical activity. Failure to meet this need can result in overtraining or fatigue and cause temporary illness, such as colds or flu. When the body is tired, performance diminishes, and this may hinder potential training adaptations. It may be necessary to review training plans and also an individual's eating behaviour to balance energy requirements. Chronic health conditions also affect exercise potential and require exercises to be modified prior to participation. A client who is obese, for example, may need to perform low impact or non-weight bearing activities such as swimming or cycling. It should be recognised that clients with chronic health conditions should be supervised by an appropriate qualified instructor, either a level 3 exercise referral instructor for a referred client or a level 4 specialist instructor for specialist programming. There are many other influencing factors affecting an individual's physical fitness and should all be considered when creating a client program within the scope of practice and limited by your qualification and experience. There are also factors to consider when working with clients of specialist population groups. We will look at these groups and their exercise contraindications and safety considerations in the coming slides. Working with any special population group on a regular basis requires a full understanding of the specific needs of individuals within that group. There are 4 different populations that are considered specialist and include young people, which are classified between 14 and 16 years of age, older adults, which are classified over 65 for apparently healthy individuals, or over 55 for individuals with at least one clinical health condition, pre- and postnatal women, who are women carrying or have recently given birth, and the final special population group is disabled individuals, who are classified as having any physical or psychological condition limiting their ability. Fitness professionals have a duty of care to all individuals who they work with. There are further specialist considerations to be accommodated for when working with individuals from specialist population groups. These include always performing a comprehensive health screen, such as a PAR Q or a PAR Q+, to ensure that a client from a specialist population has no contraindications for exercise. If an individual is apparently healthy, then they can participate with adaptations suitable to their specialist group. If an individual is not apparently healthy, as they have identified in their health screen, then they will need to be signposted to a GP where they require either clearance or referral to exercise. Working with any specialist population group who are healthy on a regular basis requires additional qualifications suitable to the specific population group. To work with clients who have been referred, a suitable exercise referral qualification must be obtained. As Professional Code of Conduct states, fitness professionals can only work within their professional competency. We will cover the recommendations and the considerations for the different specialist population groups in a little bit more detail now. As we age in our teenage years, the systems of the body are rapidly changing. This pace of change depends on multiple factors, including genetics, lifestyle, and nutritional choices. We look at some of the changes in young people now in respect to body composition, skeletal, and neural changes as growth and development occurs during this time. In relation to body composition, muscle mass steadily increases as children grow. During puberty, an increase in hormone production results in an increase in muscle mass. Hormonal differences between boys and girls mean that increases in muscle mass is greater for boys throughout their adolescent years. Girls generally carry more body fat than boys during and after puberty, and this change in both boys and girls alters the proprioception of a young person as the muscle lengths and the strength changes. This often speedy change can make individuals more self-aware, and sensitivity in this area during exercise may be required, especially in females who have an increased body weight as fat mass increases around the breasts and the pelvic area. This could give issue to exercise participation. In relation to the skeletal system, there are various stages of maturation at which bones suddenly develop at a more rapid rate. These growth spurts happen at different rates and ages for both boys and girls. For girls, it is usually between the ages of 10 and 18, growing fastest at 10 to 12 years. For boys, it's usually between the ages of 12 and 20, growing fastest at 14 to 15 years. During the growth spurt, cartilage is vulnerable to trauma and overuse. An injury that would cause a ligament sprain in an adult could be potentially serious growth plate injury for a child and an adolescent. Growth plate fractures are more common in boys than girls. Bones are not yet fully ossified in young people, having lower mineral content. This makes bone weaker and more susceptible to breaks during impact. Joints and connective tissues are also not fully developed, and caution when using fast movements and change of direction should be used. In relation to changes within the nervous system, young people are less mature and should be supervised when using weights or machines to reduce any horseplay and any incidence of accidents. Individuals will have an altered spatial awareness and reduced motor ability, so ensuring that there is sufficient space for younger individuals to train will limit any potential of harm due to accidents occurring. During puberty, hormones are changing and the body is adapting. Strength and ability perception may be altered. Young people may push the boundaries of possibilities of their limits, and the body's sensory system may not recognise this, causing potential in overheating due to the thermoregulation alterations, leading in dehydration or possible cramps. We will look at how best to accommodate these changes now and possible modifications which may be required with this population group. Healthy 14 to 16 year olds can be accommodated with regular exercise sessions with basic modifications. However, attention to the following considerations and precautions of this population group needs to be considered. In respect to considerations of young people, changes to an individual's physical development should include suitability to some equipment due to shorter limb lengths. Gender differences in strength and training preferences, along with the suitability of equipment relative to the goal and fitness, should also be considered. An example of this may be boys wanting to use free weights over girls who may prefer cardiovascular exercise. Whichever mode of exercise is used, consideration to technique should always be prioritised over intensity levels. The same can be said for ensuring a skill level is accomplished with an exercise before progressions of the exercise are made. As with all population groups, any condition indicated on a health screen will be a contraindication to exercise and will need a qualified exercise referral professional to programme and supervise that individual. There are also precautions which instructors need to be vigilant with within this population group, including a rise in core body temperature due to thermoregulation impairment of young people. This could possibly lead to dehydration or stress. Younger people have a smaller heart, which is why it's required to beat much faster to ensure sufficient blood is pumped around the body's systems during physical activity. By ensuring submaximal work with regular rest periods can reduce the stress on the cardiovascular system. Young people often lack motor skill, reducing technique and coordination, and end up with poor economy of movement. So heavy relative resistance training may have a greater risk than reward and lead to musculoskeletal injury. Activities to avoid until they reach physical and skeletal maturity include powerlifting, bodybuilding, and maximum resistance lifts. Agility training and repetitive impact, such as plyometric and ballistic training, should be avoided due to the potential stress fractures within the long bones. Similarly, flexibility techniques such as partner stretching and proprioceptive neuromuscular facilitation should be avoided with the aim to stretch only to the point of mild tension and avoid overstretching. This is due to the already stretched grown muscles and connective tissues within young people. If you are looking to work long term with individuals from a young population, then it's recommended to seek further training to gain a greater understanding of both the physiological and psychological changes that affect individuals within this group. It is also recommended to gain the consent of a parent or guardian when working with this population group for safeguarding. The primary development of sessions for this population group should be based on postural control, not intensity, and making exercise fun and enjoyable for the individual. Session considerations for young people, including the warm-up, main component, and cool-down elements, typically include the warm-ups being longer and more gradual, of around 15 minutes in length, and building on the range of motion of mobility exercises gradually. Slow controlled movements with a focus on correct posture, alignment and technique should all be encouraged throughout the session and promoted during the warm-up. The main element of the session should consist of both cardiovascular and resistance training methods, both at a lower working intensity than a typical adult's training session. Activities with less impact and less movement complexity should be prioritised, with frequent and longer rest times promoting rest and recovery being planned for and encouraged throughout. When planning a cool down, young people recover quicker, so less time may be required for a pulse lowering activity. Promote stretching for specific muscles which have been used during the workout, and encourage to hold to mild tension only. A preference of static stretches to maintain flexibility over developing flexibility is recommended, and encouragement and reminding the individual to continue to hydrate throughout the session and over the next hour post-session. Also encourage the individual to have something to eat, will replace the fluids and the energy lost throughout the training. A healthy young person can be reasonably accommodated in regular exercise with appropriate adaptations to meet any specific age-related needs. The current ACSM Fit Training Principle recommendations to consider when creating programs for young people include moderate intensity activity between 50 and 65% of maximum heart rate for cardiovascular activity of 60 minutes daily, with the addition of moderate intensity resistance training of between 45 and 80% of 1 repetition max for 10 to 30 repetitions over 1 to 5 sets, balanced across the major muscle groups between 3 to 5 times a week. It is also recommended that young people maintain their flexibility with 10 to 30 second hold of stretches over 2 to 3 days a week for all of the major muscle groups. As we age, the systems of the body degenerate. The pace of degeneration depends on multiple factors, including physical activity, lifestyle, and nutritional choices. We will look at some of the natural occurring changes as we age, specifically the musculoskeletal, cardiopulmonary, neural, and metabolic systems. Musculoskeletal aging affects the different tissues in the following ways. There is a loss of fast twitch muscle fibers and a proportional increase in slow twitch fibers, along with the development of sarcopenia, which is the loss of muscle mass as we age. This makes fast, powerful movements gradually more challenging the older we get. There's a reduction in bone mass due to osteopenia, and connective tissues, including ligaments and tendons, lose their elasticity as elastin fibers that facilitate stretch are replaced with collagen fibers. Synovial membranes within the joint are also less active, and synovial fluid becomes more viscous, with joints becoming stiff and calcifying due to both wear and tear and reduced activity and range of motion. The cardiovascular and respiratory systems, known as the cardiopulmonary system, both change due to aging, where the maximum heart rate is reduced and the heart muscle itself becomes less elastic. This reduces both stroke volume and cardiac output, making higher intensity activity more difficult to achieve and sustain. Blood vessels are lost and become less elastic due to atherosclerosis. This reduces the potential for gaseous exchange. This loss of elasticity also occurs in the alveoli, causing a reduction in the surface area and consequently a reduction in the efficiency of gaseous exchange within the lungs, limiting the ability of the respiratory system and lowering the supply of oxygen to the body's systems. In relation to the nervous system, it also becomes less efficient as aging progresses. Neural pathways are lost, and both motor and sensory receptors become desensitized or non-functional. This can lead to the loss of both fine and gross motor control and a gradual loss of cognitive ability, such as dementia and sensory decline. A loss of neural networks reduces muscular activity, and an increase in sedentary behaviour leading to a reduction in basal metabolic rate also becomes apparent. The overall result of nervous system degeneration can increase disorientation, clumsiness, and risk of falls in this population group. We will look at how best to accommodate these physiological considerations now. The American College of Sports Medicine defines an older adult as an individual over the age of 65 or over 55 with at least one clinically significant health condition or physical limitation. Most healthy adults can be accommodated with regular exercise sessions with basic modifications. However, attention to the following considerations and contraindications of this population group need to be considered. In respect to considerations of older people, everybody is different, and to focus on an individual's functional ability, not their chronological age, should be accounted for. As the body degenerates, reduction in function means the body's ability to develop power and momentum is limited as functional capacity is reduced. This reduces an individual's mobility and ability to carry out previously simple skill activities such as throwing, jumping and catching. This is due to impaired motor control within the central nervous system. This impaired motor control and loss of muscle tone can affect an individual's static and dynamic posture, making some exercises or activities difficult, and a non-optimal technique may have to be present. Adapting exercise by regressing them to a simpler form and including activities to support balance and coordination, which will in turn support an individual's daily activities, will be beneficial with this population group. As with all population groups, any condition indicated on a health screen will be a contraindication to exercise and will need a qualified referral fitness professional to program and supervise the individual. Typical contraindications to exercise with the older population includes any unstable medical conditions such as diabetes or angina, and the use of any prescribed medications to control these unstable or chronic conditions. Individuals having either a resting blood pressure of 180 systolic over 90 diastolic, or a resting heart rate of over 100 beats per minute before exercise, or any recent unexplained dizziness, should be advised not to exercise and signposted to their GP for clearance or referral to exercise. If you are looking to work long term with individuals from this specialist population group, then it's recommended to seek further training to gain a greater understanding of both the physiological and psychological changes that affect this age group. As with all population groups, a comprehensive pre-screening process is essential, and all medical conditions would necessitate signposting to a GP prior to participation. The primary development of sessions for this population group should be based on balance, coordination, and activities which support daily living. Session planning for older adults, including the warm-up, main component, and cool-down elements, include the warm-up being longer and more gradual, around 15 minutes in length, and building upon the range of motion of mobility and exercises gradually. Slow controlled movements with a focus on correct posture, alignment, and technique where posture allows should be encouraged above all else. The main component of the session should consist of both cardiovascular and resistance training, both at a lower working intensity and volume than the general population. Activities with less impact and less movement complexity should be prioritised, with stable positioning for all exercises ensured. A focus on stability and core work should be prioritised, ensuring any contraindicated exercises are adapted for, such as supine lying or extreme spinal flexion. This is due to possible restriction in range of motion and postural limitations of the individual. When planning a cool down, older adults recover slower, so more time may be required for pulse lowering activities, with a slow reduction in intensity to reduce any possibility of blood pooling occurring. Promoting stretching for specific muscles which have been used during the workout, and encourage to hold these stretches to mild tension only. A preference of developmental stretches to increase the flexibility of an individual is recommended. All flexibility exercises should be completed from a suitable and stable position, reducing the risk of any falls. In completing the session with the individual, if there's any specific mobility work which needs to be completed, consider a reduced range of motion. This will reduce any possibilities of any muscle strains or connective tissue damage. A healthy older adult can be reasonably accommodated in regular exercise with appropriate adaptations to meet any specific age-related needs. The current ACSM Fit Training Principle recommendations to consider when creating programs for older adults includes moderate to high intensity activity between 50 and 85% of maximum heart rate for cardiovascular activity of around 20 to 30 minutes over 3 to 5 times a week, with an addition of moderate intensity resistance training between 40 and 70% of 1 repetition max for 10 to 15 repetitions over 1 to 2 sets. This should be balanced across the major muscle groups between 2 and 3 times a week. It is also recommended that older adults develop their flexibility with 30 to 60 second hold of stretches on 2 to 3 days a week for all of the major muscle groups. Women's bodies change throughout their pregnancy and postpartum, with the general effects of pregnancy including an increase in heart rate, stroke volume, cardiac output, and respiration rate. There are also specific changes which occur in women during the different trimesters of pregnancy. It is important to understand these changes to enable suitable adaptations to both activity and exercise. We look at some of these changes now in respect to the first, second, and third trimesters. During the first trimester, which is from conception to week 12, there is typical weight gain of around 1 to 3 kilograms, with both breasts and the uterus enlarging. This change can cause tenderness in areas and may start to slightly alter proprioception. Hormone production is escalated, with the hormone relaxin starting to become present and altering the connective structures and loosening joints. Morning sickness may also be present at this time, and general feelings of nausea or bouts of feeling unwell may become apparent. During the second trimester, which is from weeks 13 to 26, there is a typical weight gain of around 6 to 8 kilograms during this period, which will now be noticeable and have an impact on weight-bearing joints such as the spine, knees, hips and ankles. The increase in weight, particularly in the abdominal area as the fetus grows, will alter an individual's proprioception as the centre of balance starts to change. This change in weight and centre of balance will alter the biomechanics of the mother and lead to possible static and dynamic postural change, altering both gait and spinal position from this time. During the third trimester, which is from weeks 24 to 40, there is a typical weight gain of around 3 to 4 kilograms during this time, which will make day-to-day activities more laboured as tasks become harder due to general fatigue. Venous return is also reduced and swelling in the extremities may become apparent for some women. Stress incontinence may also be a concern to some individuals as the fetus grows and starts to adopt a position for delivery and the pelvic floor muscles become weaker. This weakened pelvic floor and possible abdominal separation, known as diastasis recti, if apparent, can continue up to 6 to 12 months postpartum. We will look at how best to accommodate these changes and possible modifications which may be required for these individuals. A PAR-MEDEX document for pregnancy is a screening tool which should always be completed prior to participation of exercise to identify any possible contraindications and reasons for exclusion or referral. A healthy pre- or postnatal woman can be accommodated for with regular exercise session with basic modifications. However, attention to the following considerations and contraindications of this population group need to be considered. Acute physiological response to exercise is generally increased during pregnancy compared to those non-pregnant individuals. Therefore, monitoring during exercise is recommended and consideration should be given to which trimester an individual is in or whether they are postpartum, as this will reflect the considerations of the individual. The following are general considerations for all pre- and postnatal women. A focus on controlled linear movement and correct form, not locking any joints, should be a priority, as relaxing increases joint mobility and the possibility of injury through hyperextension or misalignment. Centre of balance will be altered, so a stable seated position which is comfortable should be considered. This will reduce the weight on the joints and increase stability during exercise, reducing the risk of any falls and possible trauma. Adapting exercise by regressing to a simpler form to support postural changes of an individual can be beneficial, along with monitoring clients for exacerbation and limiting their exertion. This will reduce fatigue and limit the impact of blood pooling due to impaired venous return. As with all population groups, any condition indicated on a health screen will be a contraindication to exercise and will need a qualified referral fitness professional to program and supervise the individual. Specific contraindications to exercise for pre- or postnatal women includes any severe anemia, second or third trimester bleeding, pre-eclampsia, which is pregnancy-induced hypertension, also multiple fetuses, and any cardiac dysfunction such as cardiac dysrhythmia, or any current unstable pre-existing condition, or multiple associated risk factors such as smoking and being obese will result in the individual being signposted to their GP or midwife. If you are looking to work long term with individuals from the pre and postnatal population group, then it's recommended to seek further training to gain a greater understanding of both the physiological and psychological changes that affect these individuals. The primary development for exercise for this population group is to maintain the current fitness levels, also to maintain the postural control and use exercises which support the activities of daily living. It's important to note that exercise should stop, and a doctor or midwife should be consulted by the participant if any abnormal symptoms occur during exercise. Session considerations when planning for both pre- and postnatal individuals, including the warm-up, main component and cool-down elements, include warm-ups being longer and more gradual, around 10 to 15 minutes in length, building the range of motion of mobility exercises gradually, being cautious not to over-exceed any optimum ranges. To ensure joint stability and control, exercises may need to be adapted to a seated or suitable standing position. Also avoiding any movements with excessive flexion or extension, such as lunges and squats, may be preferred. And by adapting exercise with impact to reduce joint and pelvic floor stress will also be preferred. An example of this would be using a recumbent bike over a treadmill for both comfort and safety. When planning the main element of the session, it should consist of both cardiovascular and resistance training methods, both at a lower working intensity and volume than the general population, and priority of using the RPE method over the contraindicated heart rate monitoring is preferred. Activities with less impact and less movement complexity should be prioritised, with movements being linear, reducing the risk of any sprains or accidents occurring. Exercise in the supine position should be avoided from the second trimester and beyond, along with lifting weights above the head and the Valsalva manoeuvre. The Valsalva manoeuvre during lifts and during isometric exercises can affect blood pressure and can increase the risk of dizziness, loss of balance, falls, and high blood pressure occurring. Hip abduction, adduction, internal or external rotation can all apply increased pressure to an unstable pelvic floor region, so these movements should be avoided, especially when working against a resistance. When planning a cool down, focus on relaxation and breathing techniques. Returning the body back to a pre-exercise state is recommended. Stretching for specific muscles which have been used during the workout and encouraging to hold to mild tension only should be promoted, with a preference of maintenance over developmental flexibility, holding the stretch for 10 to 15 seconds. Movement should be slow and controlled, with stretching on the floor or a suitable seated position advised. If cooling down on the floor, promote returning to the feet slowly to reduce any orthostatic hypertension due to the possible blood pooling effects, which may lead to possible dizziness and collapse. Active pre- and postnatal women are recommended to maintain their fitness levels during pregnancy and beyond, with previously sedentary women advised to aim for the minimum recommendations. The current Royal College of Obstetrician and Gynecologists fit training principle recommendations to consider when creating programs for pre- and postnatal women include moderate intensity between 40 and 60% of maximum heart rate for cardiovascular activity of around 15 to 30 minutes 3 to 4 times a week, with the addition of low intensity resistance training of between 30 and 50% of 1 repetition max for 12 to 15 repetitions over 1 to 3 sets, balanced across the major muscle groups between 2 and 3 times a week. It is also recommended that pre and postnatal women maintain their flexibility with 15 to 30 seconds hold of stretches on 2 to 3 days a week for all of the major muscle groups. There are many different types of disabilities, some being more limiting than others, and each with a specialist consideration in terms of activity and exercise ability. The World Health Organization defines a disability as an umbrella term covering impairments, activity limitations, and participation restrictions, some of which can be visually apparent and some which cannot. In terms of visual disabilities, they are progressive disorders, so conditions which worsen over time, such as multiple sclerosis. Careful monitoring is required to ensure that exercise program does not cause the condition to worsen. This is known as exacerbation. Asymmetrical weakness, which is also a visually apparent disability. These conditions result in a difference in strength between the left and the right sides of the body, such as those post-stroke or with cerebral palsy. The aim should be to improve the affected side as much as possible without neglecting the unaffected side. If the nerves controlling the affected side have been partially or completely damaged, the opportunity for improvement in the local muscles is greatly reduced. Spasticity is also a visually apparent disability, with many physical disabilities presenting with spastic muscles that are very tight or rigid. Flexibility training is important, however, before incorporating any flexibility program, the instructor must seek advice from a suitably trained medical authority on how to stretch a spastic muscle without causing injury. Neuromuscular disorders. These affect the central nervous system, such as muscular dystrophy. Muscles can become progressively weaker as a result of the decline of central nervous system functioning. And amputation, which affects a single or multiple limbs, affecting the individual's ability to perform certain activities and movements. Examples of some disabilities which cannot be easily identified visually include, but are not limited to, cognitive impairment, which affects understanding, judgment and behaviour, and supervision may be required for safe and effective exercise instruction and completion. Sensory conditions, which can impair vision, speech and hearing. Individuals may need additional support, such as clearly identified equipment, braille for instructions, or visual demonstrations for the hard of hearing. Psychological disorders, acquired brain injuries, and learning difficulties will all present many different challenges, dependent on the classification of the disorder or the difficulty presented. These barriers, once identified, can be mitigated with a greater understanding of the issues which the individual has faced. We will look at how best to accommodate disabled individuals and possible modifications which may be required. Prior to initial participation, it is essential to pre-screen and check for any contraindications and to seek clearance and guidance from a GP or health professional. Certain medical conditions will require interventions led by a specialist instructor, although healthy disabled individuals can be accommodated with regular exercise session with basic modifications. However, attention to the following considerations and contraindications of this population group needs to be considered. Having an appreciation that everyone has a different ability, regardless of a possible disability, and focusing on what an individual can do, ensures that everyone is treated fairly and equally in accordance with the Equality Act 2010, and reasonable adjustments to accommodate the needs of an individual must be met where possible. Exercise programs will focus on the possibilities of the individual, with preparations to adapt exercise and equipment where practically possible to accommodate all functional abilities. It is important to also consider the ongoing monitoring and evaluation of individuals' conditions. Any exacerbation to a current condition in exercise should be stopped, with the individual being signposted to a medical professional. As with all population groups, any condition indicated on a health screen will be a contraindication to exercise and will need a qualified exercise referral fitness professional to program and supervise this client. Contraindications to exercise for the disabled population are the same with any other population and include stage 3 hypertension with a blood pressure of 180 systolic over 90 diastolic, tachycardia with a resting heart rate of 100 beats per minute or more, or any heart conditions. Also any unstable medical conditions such as diabetes or angina, and the use of any prescribed medications to control these unstable or chronic conditions. Any decline in an individual's physical or psychological capability, along with a decline in any current condition, and the individual should cease exercise and be signposted to their GP or medical professional for either clearance or referral to exercise. If you are looking to work long term with individuals from a disabled population group, then it's recommended to seek further specific training relevant to the specific disability to gain a greater understanding of both the physiological and psychological changes that impact these individuals. The primary development of sessions for this population group should be based on the functional ability of the individual, with the promotion of the affected physical disability if possible. When planning programs for the disabled population group, considerations to the warm-up main component and cool-down elements should include warm-ups being regular aerobic curves on an appropriate cardiovascular piece of equipment, building the range of motion of mobility exercises gradually, slow, controlled movements with a focus on correct posture, alignment and technique should all be encouraged, and exercises modified where appropriate. The main element of the session should consist of both cardiovascular and resistance training. A physically less dominant limb should be trained first, if appropriate to do so, to maintain the balance between the dominant and the non-dominant sides. All exercise programmed should be assisted via a spotting or supporting technique where required and appropriate to do so. Activities with more complex movement patterns or complex training techniques should be pitched appropriately, and progressions and instructions may need to be layered if appropriate to do so, with exercises having a focus towards functionality to support independence and activities of daily living. When planning a cool down, an appropriate aerobic curve should be used, the opposite to that of a warm-up, to return the cardiovascular system back to a pre-exercise state. Promoting stretching for specific muscles which have been used during the workout and encouraged to hold to mild tension only, with a preference of static stretches to develop flexibility being recommended, particularly in any spastic musculature. Any restricted range of motion should slowly aim to increase over a number of repetitions post-stretching, with all movement being slow and controlled, ensuring that the client is feeling good and invigorated when completing their session. To enable effective participation for this population group, the session content may need to be adapted in relation to the specific needs of the individual. The current ACSM Fit Training Principle recommendations for disabled clients includes moderate intensity activity between 40 and 85% of maximum heart rate for cardiovascular exercise of 30 to 60 minutes, 3 to 5 days a week, with the addition of moderate intensity resistance training of between 40 and 80% of 1 repetition max for 8 to 20 repetitions over 1 to 3 sets, balanced across the major muscle groups between 3 and 5 times a week. It is also recommended that a disabled individual develop their flexibility with 30 to 60 second holds of stretches over 2 to 3 days a week for the major muscle groups of the body. You have now completed all of the content from this topic. If you have any questions from what was covered, please contact your tutor. Or if you'd wish to test your knowledge, why not try some of the mock questions? If you're happy with your progress in learning, feel free to move on to the next topic.